Patients that have that really thick, tenacious stuff, and it's only in their nasal pharynx, and you don't really have to go down all the way down to the suction catheter. So they buy a lot of these little things because this just goes into the airway, and you don't have to go down deep with it. But you'll see when you're working them. One thing I really bothers me is that you guys don't really get a good pediatric rotation. When I worked at Monmouth, I was a clinical instructor for a while, and I always made sure the students got the PD. For at least one part of, the day. We did cystics, we had a good time. But I don't do clinical anymore, so. Okay, nasopharyngeal airways. Rarely do we have to put them in, but we do have to maintain them once they're already in. And sometimes we do have to put them in. We have several different versions here. These are both oral airways. These are used on your patient who may be unconscious, but the tongue is falling back or something is obstructing their airway, and you need to keep their airway open, and you also need to have a patent route to be able to suction these people. You have to make sure that you have the right size when you attach these. One's called the Goodell and one's called the Berman. The Berman, I think, is the one that has the port down the center, and the other one has the ports down the side. When you're measuring to make sure you have the right size, now this is from the corner of the mouth to the bend in the jaw.
What is it?
To the bend in the jaw.
That's Berman, right?
Right. Well, both of your oral have to be the same way. Whichever one of the oral airways you use, from the mouth to the bend in the jaw, to make sure it's the right size. You don't want it too small, you don't want it too large. Your book gives you a couple of ways that you can insert these things. You use a tongue blade, holding the tongue down. You put it in sideways. When you get all the way back behind the tongue, then you rotate it so that it's behind the tongue. You have the flange here that sticks on the outside. You can secure this by, putting a piece of tape around it and taping it to their face. That way it won't go slip in or it won't come out. The other way the book tells you to do it is, again, using a tongue blade and put it in upside down. You're going to slide it along the roof of the mouth until it gets to the back of the tongue. And again, you're going to rotate it down so that it is behind the tongue. And again, you're going to secure it. Now your patient has a patent airway. They can't bite down. The tongue is being held forward. If you need to get down there to suction them, you can put a suction catheter down the side. And they will probably get a lot of mucus, so you can get in with the suction catheter and clean out the back of their throat. Sometimes you might even be able to get in with the yank power.
And what's the purpose of the...
Keep the airway open.
Just to keep it open. You're not putting any tubes into it or anything? Or?
Mm-hmm. It stays in there just like that?
Mm-hmm.
This would be for a patient that's not with it at all.
Right.
Because you couldn't leave
They wouldn't keep it in. And I think probably if you tried to put that in somebody who was reasonably conscious, they would probably fight you tooth and nail.
Oh, yeah.
Sometimes in the hospital when the patient's intubated, now this particular thing has...
Don't they put those in so they don't bite?
So they don't bite through the ET tube.
Yeah.
That's what I was just getting ready to say.
Okay, yeah.
If the patient does not have this one has a little block in there that prevents them from biting, because this tube is kind of soft, they could bite through it. And sometimes the nurse will call you up and ask for a bite block. What she's asking you for is for you to put an oral airway in to prevent the patient from biting through the ET tube. Because when they bite, it sets up a resistance and you get a high pressure alarm the whole time. So then instead of them, instead of you having, if they don't have something like this that has a little bite block built in, then you would just put one of these in beside that ET tube, tape it to the tube, and then the patient won't be able to bite through the tube. The other one is your nasal pharyngeal airway. Some people refer to it as a nasal trumpet. They come in different shapes and sizes. There is no specific criteria as to what size you use. The important thing is the length. You want to make sure it's long enough. You don't want it to be too long or too short. You notice that it has a nice flange to keep it from sliding in too far. It has a slightly beveled edge. It's preferable that the beveling is towards the inside so that you're making sure that when they're breathing, or if you have some kind of oxygen device attached, you're getting the full amount of the flow of the oxygen. If it is all possible, the beveling should be towards the inside. As I said, it comes in sizes, but there is no specific criteria as to what size you use, just that you make sure that it's long enough. This guy has a small nostril. Put it in this guy over here. You want to lubricate it before you put it in. Make sure you put the Surgilube on, and then you're just going to slide it down, kind of rotating if you have difficulty. Now, like with the suction catheter, if you hit resistance, don't force it. You're just
This
going
is
to...
also sterile, right?
Aseptic, yeah. I'm going to slide it in. That one doesn't fit too well. Let's try this one. This guy's got a small...
And would you do that same thing? You'd bring up several sizes and see which one was the best?
That's the only way you can determine, because there's no criteria for how determining what size you're going to put in these people. I'm having trouble finding one to fit him right now.
Now, Mary, why would you be doing this? This is just if they have secretions in the back and not in their...
If they've had facial trauma, if they've had surgery, if there's something with the jaw and they can't maintain a patent airway, but they're breathing on their own, so they don't need an ET tube. If you have to suction them frequently, say you have that person who really does need to be suctioned every 2 hours. Okay, that doesn't mean that you're going to go up and automatically suction every 2 hours. You're still going to assess them and listen to make sure. But if you know that you're going to be suctioning this person every 3 or 4 times a day, you don't want to keep causing trauma to the nasal mucosa, you put this in and leave it in. And then you just suction down through there. Huh?
I feel like it would be harder to breathe. You'd get less air.
Huh?
I feel like because it's so big, you would get less air through your nose.
Yes, well, hopefully you can. The baby patient can breathe good enough to get a little air in. It's got a flange. You can somehow kind of secure it with a gauze or a tape or something so it doesn't slide all the way in. In order to make sure you have the right size for your patient, once you're in, you want to get a tongue blade and a flashlight, pull the tongue blade down, look in their mouth, and you want to see this just below the uvula. You don't want it hanging down all the way, and but you want to make sure that you can see it. You don't want it up above the uvula. So you want to look in and make sure you have it in the proper position.
But when you insert the suction catheter in the trumpet, it's going to go beyond the hole.
It's still going to go beyond it, but you're not going to be causing trauma to the nasal mucosa every time you suction. You can actually cause people to bleed quite a bit with suctioning, especially if they're prone to bleed, if they have a bleeding disorder, if they're on blood thinners. Sometimes you just hit a blood vessel and it just starts to bleed. You have to watch out for that. Okay, so the other thing that you're going to see in the hospital, this is called an LMA, a laryngeal mask airway. And it seems to be misaligned. As again, you see it comes in various sizes. Now, when you put this tube in, and we're going to do that next semester, when you intubate, it has to be, it's a very skilled procedure. It requires a lot of practice, and you need a laryngoscope and all this other stuff to put it in. This you do not. This you just stick in. So, it has a cuff. It has this nice soft cuff around it. Before you insert this, you have to make sure you completely deflate the cuff. Lubricate it. Using your finger as a guide. You want to insert this so that it's right above the epiglottis.
Did you
And
still put
then
it on
you're
the
going
side
to
and rotate?
Did
you just put it on towards
What
the
does
side and
this do?
rotate again?
You don't rotate, you just push it right in. Because you can't rotate. Look at the size of this thing.
Oh my God.
You just
Would you say
slide it
right
in.
behind?
Right above.
Right above.
And what does this do?
It keeps the patent airway. They use this a lot in the OR now. Instead of intubating the patient, they'll put in the LMA because the ET tube goes all the way down to the bifurcation, whereas this just hits right above the epiglottis. So they don't need special equipment. They don't need to be specially trained. You just slide it in.
The whole purpose of that cuff on the bottom so it doesn't move?
So it doesn't move, and it's blocking off the esophagus.
Okay.
So all the air is going. That's why it's made this way, so that this is pointing towards the airway, where the esophagus, which is behind the trachea, is blocked off. So they can ventilate the patient through here. But you have to make sure that your tube is blown up. Your cup is blown back up again.
How much? Just that? Oh, just the whole.
Yeah, just fill it up. When you do your checkoff, I would recommend you use this one. It's extremely small. Most of the ones I have are big like this, and I don't think some of the big ones will even fit into any of our mannequins. I haven't tried this one yet. It might.
It looks really big.
Yeah.
Really?
But, you know, just to make it easier on yourself, use the little one.
Do you get toast on?
I did that.
They're so cute.
And then we have the combi tube.
What is it called?
Now, I was thinking that you probably would never see the combi tube until, I think it was, who was she yesterday? Regina said they still have people coming in, like the paramedics use it. Patient goes out in the field, and instead of having to intubate, they can just stick this in without any special. Again, it's something that you just stick in there. And it doesn't matter whether this goes into the trachea or the esophagus. That's why you have these two openings here. If you look at this, you actually have two tubes. You have two balloons. You're going to lubricate this up, open the patient's airway, and you're just going to slide it in. Once it's in place, and the way you know it's in place is that the patient's teeth should be at the black marks here. Then you know it's in. That just lets you know that it's far enough down. That's all that tells you. You still do not know whether you're in the esophagus or in the trachea. You're going to blow up both balloons. And as you can see, my balloon has been blown up 1,000,000 times. You're going to blow up both balloons. You're then going to use your manual resuscitator. And you're going to bag the patient. Now, you put it on this side. There's an opening right here. If you're in the trachea and you start to bag the patient, you're going to be listening to breath sounds and looking for chest excursion. You're going to hear breath sounds, and you're going to see the patient's chest rise. If you put it on here and you start doing this and you don't hear breath sounds and you don't hear the patient's chest rise, that means that you're in the esophagus. Then you're simply going to take it off this side and put it on this side. This one has a blind, there's no opening down there. It's a blind end. But you have holes up here. So even if you're in the esophagus, you're not going to be pushing air in the patient's stomach because this is closed off and you have a cuff here that's blown up. You also have a cuff here that's blown up to prevent the air from coming back out. But these holes are right at the level of the trachea, of the bifurcation. So by bagging, now you should be able to hear breath sounds and to see the chest rise because now you're ventilating through here.
Even if you're still in the esophagus?
Well, that's the whole point. If you're in the trachea, you're going to be ventilating through this side. If you're in the esophagus, you're going to switch over to this side.
It has the mechanisms to be able to ventilate in whatever hole you're in so that you're not going to call, you know what I mean?
That way you don't have to keep pulling it out.
So does the air just come out of the esophagus and go into the...
It has holes, so it's coming out up to
at
the
the
top
level of the
and the trach,
bifurcation.
it would come up.
It's not going to come out this side. You're at the level of the bifurcation, so the air is going to be coming out here, going into the lungs, right?
And then if you're in the trach, it's going to have it so that its mechanism is so that you're not going to cause damage.
Okay. See, the one side is open, the one side is closed on the bottom. And the side that's closed has holes in the area above the cuff. You see that?
Mm-hmm.
Combi, what was the name?
Combi tube.
And you use a, how do you fill it with the balloons up?
A syringe.
Just a syringe.
You have this huge syringe, and you just, last year they actually pulled the thingies off. The students pulled it.
So it has something
like
like-
why, but they did.
We'll have something like this too.
Yeah, it will have something like this attached, one here and one here. So you just put a syringe on and blow up the cuffs.
Wait, where would they have been? They can't be
One
down there.
would be attached up here. As a matter of fact, it was attached right here.
I didn't know
How?
And the
If
other
they're
one
going
was
in,
attached.
how
Huh?
is it? How could you blow it up if it's going inside?
Because it comes out to the outside, just like this one.
Oh, okay.
How much do you know?
Now this is inside, but the cuff is long enough to come to the outside so that you can blow it up once it's inside the patient.
This is a
The
confusing
same would apply here. They're attached here,
Yeah.
but it comes far enough out so that you can attach a syringe and blow it up.
How much do you know how to blow it up with? Like how much do you?
Usually when you start to feel resistance, you know it's
air's
pretty
coming out
much
of the
all
side. You're
the
still
way
in the
going. There's
esophagus, but
no
the air's
idea
coming
how
out
much
here
air you put in.
instead of down here.
Okay,
the
so
way
the
that it's coming
combi
out, it's
tube,
not going to cause
the
damage. It's coming
LMA,
out the right
the
way. It's not just like air
nasopharyngeal,
just
and the
spewing out.
oropharyngeal are the 4 airways that you need to be aware of.
What?
the LAN, the
LMA.
LMA,
That's a good way to remember it, though.
What else was it? Oh.
The combi tube, the LMA, nasopharyngeal, oropharyngeal.
Just a lot of stuff, Mary.
It is
For
a
one
lot of
check
stuff,
off.
but it's something that a lot of times you will see this when the patient starts to code. Okay, and you're going to be doing a bag mask ventilation. This helps keep the airway open while you're bagging the patient. If you can get one in, sometimes you can't always get one in, but when you can get one in, it helps keep the airway open, make it easier for you to bag.
And we would do that? We
Huh?
would put that in?
You would put that in. Sometimes they will come in, if they're coding on the field, sometimes they'll come in with it in. I guess that's about all. Okay.
So Mary,
These
you
come
were
in
just
sizes,
showing
look
us
at that.
You were just showing us the nasal trumpet on the intubated patient because his nostrils were larger, but you would never use that on a patient that's intubated because they already have the
Right,
suction
they have an
tube in.
airway in already.
Okay.
Yeah, this guy's nostrils, I tried him yesterday, they're kind of small. I don't know.
So would you do it on a trach patient?
You would do it on a patient that's breathing
I could
on
probably
their
get
own.
no, I can't even get an oral one in here.
Looks like it blocks your airway, huh? Doesn't it?
If you're going to be suctioning
Any
them a
questions
lot.
about
No, if they
suctioning
have
or
trauma.
airways?
Yeah. If they have facial trauma, frequent suction, jaw injury,
That's
not a
it.
patent airway,
Isn't that enough?
flashlight.